everyone. So yeah, we have the MCQs which we are discussing every day. So the first MCQ is we have today is which is the most common site of sequestered lung segment, and the options are it's a apical segment of the right upper lobe, it's a apical segment of the left upper lobe, or it's a posterior basal segment of the left lower lobe, and the last option we have is the posterior basal segment of the right lower lobe. So yeah, basically we are discussing the MCQs here. And the question is which is the most common site of sequestered lung segment, and the options are it's a apical segment of the right upper lobe or apical segment of the left upper lobe, and then we have the posterior basal segment of the left lower lobe, and then the posterior basal segment of the right lower lobe. So if anyone wants to answer this most common site for that is the most common site of sequestered lung segment. So yeah, if you want to answer this, which is the part which is the most common site for sequestered lung segment. Sequestered lung segment is basically in that segment which is not, you can just say it is not connected to the other part of the lung. So yeah, D, no, it's not D, basically C is the posterior basal segment of the left lower lobe and not the right lower lobe. So yeah, and majority of the sequestration are located in the left lower lobe and it's not the right lower lobe. And as I said, there is a dysplastic lung tissue and there is no communication between all the structures. So yeah, it receives an anomalous vascular supply and it is a non-functional tissue. Next we have, it's a very interesting question. The question is, while evaluating a patient with a suspected oral polyp, you apply a Segal speculum and observe that the mass pulsates vigorously and then branches. So what is the sign called as? It's a rising sun sign, squarch sign, it's a lighthouse sign, or it's a brown sign. So it's a very interesting question. If you know, you can just answer. I'll just repeat. While evaluating a patient with a suspected oral polyp, you apply Segal speculum and observe that the mass pulsates vigorously and then branches. So what is the sign called as? It's a rising sign, squarch sign, it's a lighthouse sign, or it's a brown sign. So yeah, just remember in the diagnosis, whenever you see a pulsating mass in the oral, that is in the ear, so what do you think? It's a pulsating mass. Anyone? What is a pulsating mass in the ENT? So if you can just think of it. So yeah, okay, I will just tell. So main confusion here, it will be your brown sign, lighthouse sign. It will be very confusing for you, but yeah, I will just tell. See, in Glomerus tumor, so the diagnosis which we are discussing here is that Glomerus tumor. So in case of a Glomerus tumor, yeah, it's a glomerus jugular. So in case of a Glomerus tumor, basically you will see a pulsating mass. And answer here is brown sign, because brown sign is basically the pulsation sign which suggests the Glomerus tumor. So there will be a confusion between Glomerus tumor and that is a brown sign, lighthouse sign. Lighthouse sign is basically there will be a pulsating, that will be it's a pulsative discharge. So yeah, if they tell you a pulsating discharge from the tympanic membrane due to perforation, basically it's a pinhole perforation of the pars sensor that to be seen Myocarditis. So then it will be a lighthouse sign. But if they tell only that is pulsating mass, it's a Glomerus tumor and that's a brown sign. And we had other options like rising sun sign. In rising sun sign also it is for Glomerus tumor only. We will see a rising, it will be a Glomerus tumor arises from the floor of the middle ear. So yeah, it's a Glomerus tumor again. And squarch sign is basically it's seen in otosclerosis, if you just remember. It's a squarch sign. And they have just given it's a reddish hue seen on the promontory through the tympanic membrane in case of otosclerosis. So yeah, next question we have, it's a UGP regimen of emergency contraception consists of which of the following? The options are very simple. It's etonorgestrel plus ethinyl estradiol, or we have a levonorgestrel ethinyl estradiol. It's a levonorgestrel plus desogestrel, or the last option is norethistone that is an enanthate plus estradiol valerate. So I'll just repeat, it's a VUGP regimen. So we are talking about a VUGP regimen of emergency contraception consists of which of the following? I'll just repeat, it's a etonorgestrel plus ethinyl estradiol, it's a levonorgestrel plus ethinyl estradiol, it's a levonorgestrel plus desogestrel, or it's the last one is the norethistone enanthate plus estradiol valerate. So yeah, if you can just, yeah, I got right answer I got. So if you want just know the answer, you can just tell what is the UHP regimen for emergency contraception. So yeah. So basically I will just tell it's a combination. It's a combination of, yeah, the B is the right answer. It is a combination for levonorgestrel plus ethinyl estradiol, that is a regimen for emergency contraception, and it includes 2 doses. We have to give 12 hours apart. You have to give, and within 72 hours of an unprotected intercourse. So it has higher incidence of nausea, vomiting, less efficacy than progesterone only standard regimen. But yeah, you have to remember this. It's a levonorgestrel plus ethinyl estradiol. Let's say emergency drug, and that to within 72 hours. See, you might have seen in the ads also. It's an eye pill. So yeah, it's a levonorgestrel plus ethinyl estradiol as the content for a use per regimen. Next we have what is a Molotov cocktail. So yeah, if you know what is a Molotov cocktail, options are alcoholic poison, that is an incendiary bomb, acid bomb, or it's a rifled forearm. Forearm means firearm, sorry. So yeah, if you can just tell me the answer. What is a Molotov cocktail? It's an alcoholic poison, incendiary bomb, acid bomb, or it's a rifled firearm. It's a forensic question. So yeah, if you can just tell, others I will only tell. Okay, the answer is it's a B, right? The incendiary bomb is also called as Molotov cocktail, and it is thrown by the hand. It is a type of crude bomb. I don't know why in medicine we are talking about bomb and all, but yeah, you have to remember it's a Molotov cocktail, which is an incendiary bomb. So it is filled with gasoline and a rag to serve with a wick, and the wick is lit and thrown at a target. So yeah, next we have it's a calculation question. We have the mean value of marks in a distribution of 100 students in a class is 105 and standard deviation is 10. So how many students will have their marks between 85 to 125? 68%, 50%, 99.7, 95%. So I don't know why though they give for the exams, but yeah, there is no choice for us. So yeah, mean value for the 100 students is 105, standard deviation 10. So how many students will have their marks between 85 and 125? Options are 68%, 50%, 99.7% and 95%. So yeah, if you know the answer, you can just message here or you can just answer it. So yeah, anyone wants to answer? Basically it's a calculation question. So I'll just tell the answer here. It's 95%, and yeah, I got it wrong, but yeah, it's a 95%, and according to the empirical rule, you have to just find out the standard deviation is given 10, and we have 100 students, and the mean is 105. So according to this, there will be a mean plus minus 2 SG, and in that case there is a normal distribution. I also don't know basically here, but yeah, there is some normal distribution, and 90 in this scenario the marks between 85 to 125 falls within the 2 standard deviation of the mean, which is a 105. So 95% of the students will have the marks in this range. So yeah, basically it's a PSM question, but yeah, we'll move on. What is the minimum cutoff for defining proteinuria in a random urine sample? So yeah, if you know the answer. So what is the minimum cutoff for defining proteinuria in a random urine sample? It's a 0.3 gram per dl, 0.2, 0.1, or it's a 0.4 gram per dl. So yeah, anyone wants to answer this? What is the minimum cutoff for defining proteinuria in a random urine sample? It's 0.3, 0.2, 0.1, or it's a 0.4 gram per dl. So yeah, if you can just remember the value. So yeah, cutoff for proteinuria. Okay, the answer I will just tell. It's basically, if you can guess also, but if you don't want to guess, the answer is A, that is 0.3 gram per liter. So yeah, normally what we tell is it's like a greater than 30 mg per dl. That is only. But yeah, in a random urine sample, and you consider proteinuria when it is greater than 0.3 gram protein in a 24-hour urine sample and all that till then. But yeah, so you do a urine dipstick method and all that. We do it for if the quantitative methods are not available. So yeah, and just one more thing, proteinuria is not an essential criteria to define platelets. Here we have a criteria that is BP and all that is 140 by 90. I guess it's greater than 140 by 90 and all. So next we have a patient with a spinal injury presents with a decreased sensation over the radial aspect of forearm, thumb and index finger. There is a weakness of the wrist extension on examination. So which nerve root has been damaged here? So yeah, it's a very that way anatomical question, but yeah, a patient is there with spinal injury presents with decreased sensation on the radial aspect of the forearm, thumb and index finger. So there is a weakness of the wrist extension on examination. So which nerve root has been examined? So it's not the lateral or the medial, but they have just given it's a radial. Yeah, they have given the radial arc, that is the lateral part of the forearm. So what I think is, Yeah, I'm right. So if you want to answer this, which is the nerve root will be damaged in this case? Now, that is a loss of sensation over the radial aspect of forearm, and there is a weakened wrist extension. So yeah, the right answer is C, right? Is C6. So C6 nerve root has been damaged here, causing the loss of sensation over the radial aspect of the forearm, and there will be a weakened wrist extension. Next we have a question that a 35-year-old male with a chronic bacterial prostatitis was treated with cortimortazole. So within few days he developed malaise, jaundice, abdominal pain and dark urine. So the blood picture is given below. So what is the likely diagnosis they are asking? So yeah, I will just tell you what is the blood picture. The blood picture is very simple. It's it's a hemolysis, I think. Yeah, it's a acute hemolytic condition. So yeah. Okay, I'll just repeat the question. The question was, it's a 35-year-old and with the chronic bacterial prostatitis, and you gave him cortimortazole. So within few days he develops malaise, jaundice, abdominal pain and dark urine. So the blood picture is given below, which shows a hemolytic condition. So what is likely diagnosis? So the options are hemolytic uremic syndrome, autoimmune hemolytic anemia, Carcinoma nocturnal hemoglobinuria, or it's a GCPD deficiency. So yeah. Anyone wants to answer? It's a hemolytic uremic syndrome, autoimmune hemolytic anemia, paroxysmal nocturnal hemoglobinuria, or it's a GCPD deficiency. And why? If you know the answer, just tell me. Why? I will only tell. So yeah. Anyone wants to answer? Okay, the answer is very simple. It's see, I also thought it's a hemolytic condition, but yeah, it's a hemolytic condition, but it is due to GCPD deficiency. So D is the right answer here. So clinical features suggest of an acute hemolytic reaction. That too you give after cortimortazole, you give that, and it will cause that. So this is suggestive of GCPD deficiency. And what happens in GCPD? You know, there will be oxidative stress. That is uncontrolled oxidative stress will be there and causes hemoglobin to denature and form Hange bodies. So if you tell that is a Hange bodies, just move on to GCPD deficiency. So yeah, removal of the Hange bodies by the macrophage in the spleen results in the formation of a characteristic bite cells. So if it is a bite cell and it is a Hange, it can be a bite cell or the blister cells. So yeah. So next we move on. Basically, you have to remember it's the adverse effects of that cortimortazole. The drugs that carry the risk of clinical hemolysis in the person with GCPD deficiency is cortimortazole. Also is one of the drugs which will cause hemolysis in a person with GCPD deficiency. Next we have, all of the following are gastrointestinal manifestations seen in patient with FAP, that is FAP, except it's a gastric and duodenal polyps, fundal gland hyperplasia and a gastric polyp, or it's like an ampullary carcinoma, or the last one is the esophageal carcinoma. So yeah, you know what is FAP first. If you don't know FAP, you want to be full form of FAP. If you know the full form of FAP, FAP basically it's a familial adenomatous polyposis. Okay, I'll just repeat the question here. All of the following are gastrointestinal manifestation seen in patient with familial adenomatous polyposis, except options are gastric and duodenal polyps, it's a fundal gland hyperplasia and a gastric polyp, it's an ampullary carcinoma, it's a esophageal carcinoma. So yeah, if you know the answer, which of the following are gastrointestinal manifestations seen in patient with FAP, except. So anyone wants to answer? It's a case of a familial adenomatous polyposis. So yeah, if you want to answer this. Okay, the answer is basically except they have given. So yeah, it's a esophageal carcinoma. So esophageal carcinoma we basically don't see that is in FAP, that is a familial adenomatous polyposis. And what we see, gastric and duodenal polyps we see, because polyposis means there are many, multiple polyps will be there in your GIT. So yeah, gastric and fundal duodenal polyps will be there. There will be a fundal gland hyperplasia in the gastric polyp, and the last one was ampullary carcinoma will be there. But no, it will not go to the esophageal carcinoma. So yeah, that we have to remember. Duodenal polyps are adenomatous in nature and pretty malignant, but it will not go to the esophageal carcinoma. It's only towards the ampullary carcinoma. So yeah, there is an increased use of duodenal ampullary carcinoma. Next we move on. Which is the HPV serotype most commonly associated with carcinoma cervix? Options are 16, 18, 31, 33. Anyone wants to answer? Which is the HPV serotype most commonly associated with carcinoma cervix? It's an easy one. 16, 18, 31 or 33. So yeah, if you know the answer, it's a silly mistake if you mark it as wrong, but yeah, if you want to answer this. which is the HPV serotype most commonly associated with carcinoma cervix, 16, 18, 31, 33. So yeah, okay, I'll tell you the most common is 16 and most malignant is 18. So yeah, most common serotype causing carcinoma cervix is 16, and if you are asking for the most malignant serotype is 18. Next we move on. I think it's a repeated question. So yeah, it's a next we have it's a 2-year-old child is brought to the casualty with a severe abdominal pain, and on performing emergency exploratory laparotomy, the following findings is noted. So which of the following statements is false regarding this condition? I think it's a diverticulosis. I think yeah. I'll just tell it's a okay. Yeah, it's a Meckel's diverticulum only. I was right. So yeah, it's a Meckel's diverticulum. So I'll just repeat the question very fast once. It's a 2-year-old child who is brought to the casualty with a severe abdominal pain, and you perform an exploratory laparotomy, and you see a finding, that is a diverticulitis you see. So which of the following statement is false? You see a Meckel diverticulum, yeah. So you can options are, it can be a lead point for intussusception. The most common presenting symptom is bleeding in the younger children. It is a false diverticulum with STNs from the antimesenteric side, or it's the most common heterotopic tissue is gastric mucosa. So yeah, which of the following is false? Yeah, it's yeah. Okay, you want to answer this? It's basically Meckel's diverticulum they are asking. It's a rule of 2, yeah, rule of 2 though everyone knows, but yeah, I'll just tell the answer here. So the answer, basically it's a case of a Meckel diverticulum, and they have just given it's a false. It's not a false, it's a true diverticulum. So yeah, it's a true diverticulum, that too it's extends from the antimesenteric side, and it can cause intussusception can be caused. It is the most common presenting symptom is bleeding in the younger children, and most common heterotopic tissue is gastric carcinoma. So yeah, rule of 2, rule of 2 is very simple. A rule of 2 for Meckel's diverticulum is it's a 2 types of heterotopic mucosa, that is gastric will be there and pancreatic will be there, and 2% incidence, approximately 2 inches in length, located with 2 feet of ileocecal valve, and the last is usually symptomatic by 2 years of age. So this is the rule of 2, but it is not specific these days, but yeah, rule of 2 you have to remember for a Meckel's diverticulum. So last time I will repeat, it's 2 types of heterotopic tissue, that is the gastric and pancreatic, 2% incidence, 2 inches length, 2 feet of the ileocecal valve, and it is usually symptomatic by 2 years of age. So yeah, next we have a 27-year-old man presented to the casualty with a slurred speech and a shallow breathing. On examination, you find that he has a bradycardia, hypotension, and a pinpoint pupils. So which drug will you choose to treat him? So yeah, if you know a diagnosis, just tell me. It's a nalorphine, naloxone, it's a nalpafine. So yeah, I'll just repeat, it's a 27-year-old man who comes to you with a casualty with a slurred speech and shallow breathing. On examination, you find his bradycardia, hypotension, pinpoint pupils. Which drug can you use to treat him? It's a nalorphine, naloxone, or nalmefene. So yeah, if you can just tell me the answer. So yeah, okay, basically I will just tell there is a overdose symptom. It's a opioid overdose, and the symptoms are, it's a triad of coma, respiratory depression, pinpoint pupils. So it's a very characteristic triad which you have to remember for an opioid overdose. It's a coma, respiratory depression, and pinpoint pupils, and hypotension, bradycardia, shallow breathing, and hypothermia. These are the classical features of the opioid poisoning. So yeah, so what is the drug for opioid poisoning is? The answer is, it's a drug of choice is naloxone. You have to remember there is a drug of choice for opioid poisoning, that is naloxone. So I told you all that. And yeah, it's naloxone is contraindicated in infant born to mothers with opiate addiction, and it may precipitate acute neonatal withdrawal with seizures. So yeah, and I told you all the symptoms I told you. Next we have, as an epidemiologist, you are investigating an outbreak of cholera. So yeah, it's a case of a cholera, and what is the minimum free residual chlorine level that should be maintained in the pipelines to prevent further spread of outbreak? So it's a PSM question. It's a 2 mg per liter, 1 mg, 1.5, or it's a 0.5 mg per liter. So yeah, if you can just tell me the answer. It's a cholera case. So what is the minimum free residual chlorine level that should be maintained in the pipelines to prevent further spread of the outbreak? It's a 2 mg, 1 mg, 1.5, or 0.5. So yeah, anyone wants to answer this? It's Okay, I will tell them basically there is a value between it's 0.7 to 0.9 mg per liter. So yeah, it's a 0.7 to 0.5 to advisable level of free residual chlorine in water body after decided disaster is 0.7 to 0.9 mg per liter. But if it is not a disaster, it is 0.5 mg per liter. So yeah, it's a very important thing. It's basically if it's a cholera case, chlorine will be 0.5 mg per liter, and if it is a disaster, it will be 0.7 to 0.9 mg per liter. Next we have it's a bone marrow biopsy of a normal adult given below. So what is the ratio of structures marked A and B? So yeah, I think it's a more of a I will just repeat. It's a bone marrow biopsy of a normal adult, and they have given a pathological picture here. Basically it's a fat cells. So they have given A and B. A is fat cells and B is hematopoietic elements. So basically you have to tell what is the ratio of fat cells to hematopoietic cells in case of a bone marrow biopsy of a normal adult. It's a normal patient, so there is nothing disease or nothing like that. So the options are 2:1, 1:1, 1:2, or 1:3. So yeah, it's basically you have to tell the ratio between the fat cells and hematopoietic elements in case of a normal bone marrow biopsy. Options are 2:1, 1:1, 1:2, or the last option is 1:3. So yeah, if you can just tell a normal bone marrow, you can just tell. So yeah, if you don't want to tell, it's the answer here is it's 1:1. So yeah, whenever you go for a normal biopsy, that too bone marrow biopsy, you will see fat cells and hematopoietic cell, and that too in the ratio of 1:1. If you become adult, in adult stage, basically its fat cell increases, so there will be a difference in ratio. But in normal adult, it is 1:1 ratio between the fat cell and hematopoietic cells. Next we have what is the most common sleep complaint? It's insomnia, hypersomnolence, nightmares, or sleepwalking. So yeah, it's an easy one. Just if you can tell what is the most common sleep complaint. It's insomnia, hypersomnolence, nightmares, or sleepwalking. So yeah. So you might be knowing it's a very, very common sleep complaint. So yeah. Okay, I will tell the answer here is insomnia. So it is the most common sleep complaint in all over the world we have is insomnia. And you know what is insomnia? You are not able to sleep basically. It's like difficulty initiating or maintaining sleep, and it may be transient or persistent. Yeah, it's insomnia. We also have insomnia during exams. But yeah, to treatment, what is the treatment of insomnia? You have to treat the cause. If you have an anxiety or mood disorder, you have to treat the cause. There should be a sleep hygiene and short-term therapy you can give. That is zolpidem you can give. So yeah, I won't prescribe you, but yeah, in exams and all, I won't prescribe, leave it. So yeah, short-term therapy you can't take for insomnia. It's zolpidem or xylophone. So next we have a patient comes to you with in an orthopedic OPD with an ankle sprain caused due to hyperinvasion of the right foot. So which of the following ligament is commonly injured? So yeah, if you know the anatomy here, you can just tell this answer. So basically you are in an orthopedic OPD and a patient comes to you with an ankle sprain due to hyperinversion of the right foot. So which of the following ligaments is commonly injured? Options are deltoid ligament, anterior talofibular, spring, or it's a posterior talofibular. So yeah, if you know the anatomy in the right foot and that too hyperinversion of the right foot. So yeah, if you think deltoid ligament, anterior talofibular ligament, spring, or it's the posterior talofibular ligament. So yeah, most commonly injured with the inversion sprains. Normally also we have sprains. So what is the most commonly injured ligament if you know? So yeah. Okay, I will just tell the answer here. The answer is basically it's a B, that is the anterior talofibular ligament is the most common ligament that too injured in this case because there is a hyperinversion of the right foot they have given. So whenever you have a sprain or something like that, the first ligament injury you can think of an anterior talofibular ligament based on the hyperinversion of the leg. So yeah, what they have given important ligaments of ankle present on the medial side and therefore likely to be injured during an eversion sprains are deltoid ligament and sprain ligament. And if we have an inversion sprain, which is the question they have given, it can be anterior talofibular, which is the most commonly, that was the question they have given. It can be posterior talofibular or it's a calcaneofibular ligament also. So yeah, it's an inversion and it's an exversion. So next we have, so yeah, it's a nice question. Every question is nice only. But yeah, a 36-year-old male from Bihar comes with complaints of hypopigmented macules over the trunk and face. So the nerves and sensation are found to be normal and there is no visible scaling. So the patient gives a history of prolonged fever 2 years back for which he was treated. So what is the drug of choice? I think it's a case of leprosy only, I think. Yeah, I think so. I'll just repeat the question once. It's a 36-year-old man who comes to you with the complaints of hyperpigmented macules over the trunk and face. The nerves and sensation are found normal and there is no visible scaling. The patient gives a history of prolonged fever 2 years back for which he was treated. So what is the drug of choice for this condition? So options are multi-drug therapy for leprosy, amphotericin B, deoxycholate, sodium stibogluconate, or it's a methotrexate. So yeah, if you can just tell. I don't think I was wrong basically, yeah. Because see, the nerves and sensation are found to be normal. In leprosy, basically, there will be a decreased sensation and there will be a scaling also. But yeah, so it's not a case of leprosy. And yeah, what is the case if you can just tell? It's okay, yeah, it's yeah. So basically, they have also given the history that is 2 years back, fever was there. So in that case, the diagnosis what you will get from here is a post-Kala Azar, that to leishmaniasis, dermal leishmaniasis. I know you won't be think at first, but you have to remember it. It's a hyperpigmented macules over the trunk and face, and 2 years back there was a fever. So you will have to think about a leishmaniasis, that to post-Kala Azar, dermal leishmaniasis. And what is drug of choice if you know for this case? It's a leprosy or amphotericin B, deoxycholate, sodium stibogluconate, or it's a methotrexate. So if you can just tell me what is the drug of choice for a post-Kala Azar dermal leishmaniasis. So anyone wants to answer this? Okay, the answer is, basically I will only tell, the answer is it's no, it's not NS-stibogluconate. The answer is methotrexate. So yeah, it's a methotrexate. What is a post-Kala Azar dermal leishmaniasis drug of choice? So yeah, how will you approach a case? The rashes will appear 1 to 2 years after the prolonged fever, and which suggests there will be a visceral leishmaniasis. And there are two other differential diagnoses, as I told. There are two differential diagnoses in this case, that is leprosy and tinea versicolor. But yeah, if there is no scaling, you will rule out tinea versicolor, and if there is no sensation or sensation is normal, you will rule out leprosy. So yeah, and nothing has to be told me. I methotrexate is the right answer. So yeah, next we have, it's why is October 16, 1846 important in the history of anesthesia? I don't think this question will come, but anything can come. I'll just repeat. Why is October 16, 1846 is important in the history of anesthesia? Options are demonstration of ether anesthesia, demonstration of NO as an anesthetic, discovery of local anesthetic action of cocaine, and the last is discovery of chloroform as an anesthetic. So yeah, if you can just tell October 16, 1846 why it is important. I know no one will be able to tell, but yeah, it's it was the first anesthesia, I think. So yeah, the answer is A, that is it's a demonstration of ether anesthesia. So yeah, it's okay. The first public demonstration of surgical anesthesia was in that day. So that's why we will remember that is October 16, 1846. There is the first demonstration of surgical anesthesia, that to ether we got. And October 16 is also celebrated as a World Anesthetic Day. Next we move on. You are appointed as a regional doctor in charge of overseeing the activities under the Rashtriya Bal Swasthya Karyakram. All of the following diseases are specifically covered under the purview of this program except it's a congenital cataract, vision impairment, retinopathy of prematurity, or it's a congenital glaucoma. So yeah, if you want to tell, really you are in charge of overseeing the activities of Rashtriya Bal Swasthya Karyakram, and which of the conditions are specifically, which are all the following, which are the conditions are not covered under this. It's a congenital cataract, vision impairment, retinopathy of prematurity, and the last is congenital glaucoma. So yeah, if you want to tell, it's a child head, that is the RBSK. RBSK I told, it's a Rashtriya Bal Swasthya Karyakram, and child health screening and early intervention services are there. So yeah. Okay, basically the right answer is D, that is congenital glaucoma is not covered under the Rashtriya Bal Swasthya Karyakram. And what are covered, I will just tell. The eye conditions which are covered under this is basically you have vitamin A deficiency, congenital cataract, we have the retinopathy of prematurity, and vision impairment is common, you see that. So yeah. Next we move on. Which of the following can be responsible for Bejold-Jaris reflex? I repeat, which of the following can be responsible for a Bigelow gyrus reflex? Options are serotonin, histamine, prostaglandin, angiotensin. So anyone wants to answer? Serotonin, histamine, prostaglandin and angiotensin. Bigelow gyrus reflex. So yeah. Okay, the answer is it's a serotonin is the right answer. That is A. It is responsible for Bigelow gyrus reflex, and what happens here? There is the activation of the chemosensitive vagal C fibers located in the cardiopulmonary region. So yeah, it causes profound bradycardia, hypotension and apnea. Because we are talking about that is a Bigelow gyrus reflex, and in Bigelow gyrus reflex you will have a bradycardia, hypotension and apnea followed by a rapid shallow breathing. So yeah. So which substance which can cause this? It's a serotonin is the right answer, but yeah, you can also have phenylbigoniad and viratridine. So you have to remember it's a Bigelow gyrus reflex. So next question we have, it's a thiamine deficiency results in decreased energy production because TPP dash. It's you have to tell the mechanism here. It's interferes with the alcohol mechanism. It interferes with ketolase activity. It is a coenzyme for pyruvate and alpha ketoglutarate dehydrogenase, and the last option is it interferes with the energy production from amino acid. So in chronic alcoholism, it's a thiamine deficiency will be there, but I don't know the answer, but yeah, if you can just think like that, thiamine deficiency results in decreased energy production because TPP dash. It's interferes with the alcohol metabolism, interferes with the trans-ketolase activity, is a coenzyme for pyruvate and alpha ketoglutarate dehydrogenase, or it's interferes with energy production with amino acids. So yeah, if you want to answer, TPP basically it's a thiamine pyrophosphate. Yeah, phosphate. So yeah, anyone wants to answer this? I know no one wants to answer, but yeah, well I don't think anyone will come also. 2 times a day who comes? I am also okay. Basically the answer is it's a C. It's a coenzyme for pyruvate and alpha ketoglutarate dehydrogenase. That is a mechanism for thiamine deficiency, not to which results in decreased energy production. So yeah. So if you have a thiamine deficiency, it will result in decreased energy production because thiamine pyrophosphate, that is TPP, is a coenzyme of pyruvate and alpha ketoglutarate dehydrogenase, which are required for production of ATP using NADH. So yeah, I know it's a biochemistry question, but you have to remember. So it's a coenzyme for pyruvate and alpha ketoglutarate dehydrogenase. That is a thiamine. So next we have a patient who presents with a mobile warm to touch nodule in the neck. On the anaerobic culture of the biopsy material from this swelling, it is shows colonies as shown in the image, so which had a gram positive branching rods on staining. So which of the following is drug of choice for this condition? Basically you have to tell the diagnosis here, without that you won't be able to tell. But yeah, I will just tell what is the case. It's an image they have given which shows a molar tooth colonies. Yeah, so if there is a molar tooth colonies, it's a specific for which condition, if you can remember. Okay, if I tell, okay, I will only tell the answer. It's actinomyces. So yeah, it's a case of I'll just repeat. A patient presents with a mobile warm to touch nodule in the neck, and on anaerobic culture the biopsy material from the swelling is shown as the image below, that is a molar tooth colonies, and which had a gram positive branching rods on staining. So which of the following is the drug of choice for this condition? Options are doxycycline, cortimosozole, penicillin, or surgical drainage. So yeah, if you can tell. Basically it's a case of a cervicofacial actinomyces. So yeah, if it's a case of a cervical, that is a facial actinomyces, also known as the lumpy jaw syndrome. So what is I'm not dancing, but yeah, so it's a lumpy jaw syndrome, and what is the drug of choice? Anyone? It's a penicillin. So you have to remember it's a penicillin which is the drug of choice for a condition known as cervicofacial actinomyces, and you have a molar tooth colonies. Then we have a 2-year-old unvaccinated girl brought to the OPD with a high-grade fever and maculopapular rash for 2 days. On examination, she has blue-white spots on her buccal mucosa shown below. They have given below. Which of the following vitamin deficiencies is associated with this condition? It's a E, C, K. So image they have just even given a blue spot there, but you have to tell by this only. It's a 2-year-old unvaccinated girl brought to the OPD with a high-grade fever and maculopapular rash for 2 days. On examination, she has a blue-white spots on her buccal mucosa So which of the following is vitamin deficiency associated with this condition? So yeah, vitamin A, E, C, K. So yeah, if you can answer this condition, it's a high grade fever with maculopapular rash for 2 days. So which vitamin deficiency will cause a blue-white spot on the buccal mucosa? Yeah, if you want to guess, you can just guess. It's a very easy. If you are not vaccinated, then you can just tell this. Yeah, it's associated with. Okay. The answer is it's basically diagnosis is a measles. In measles, you have seen it's a characteristic feature, and there will be in the buccal mucosa there will be it's not a blue-white, but yeah, the buccal mucosa we have something. So yeah, have something means there's a lesion. So yeah, it's an examination, blue-white spots on the buccal mucosa, that is a measles. We are going towards a measles, and it's a measles case. So in measles case, what vitamin deficiency will be there? It's A, E, C, K. Okay, I will just tell the answer. It's A. You have to remember, whenever you have a measles, there will be a vitamin A deficiency. So yeah, vitamin A therapy is indicated in all patients with measles. You know what are the vitamin A, night blindness and all that, keratomalacia, beta spots, that all you know. Yeah, then we have what is the gold standard investigation for diagnosis of myocarditis? It's a endomyocardial biopsy, MRI, brain, that is a BNP, that is a brain natriuretic peptide, LDH1 to LDH2 ratio. So if you can tell what is the gold standard investigation for a case of a myocarditis? It's an endomyocardial biopsy, MRI, BNP, that is a brain natriuretic peptide. The last one is LDH1 to LDH2 ratio. So yeah, if you can tell. Okay. See, myocarditis, it's an inflammation of the myocardium, that from a line only, But yeah, it is in case of an active myocarditis, it is interstitial inflammatory infiltrate associated with degenerative or apoptotic myocytes. That no need to tell. But yeah, in case of a myocarditis, the diagnosis, that is a gold standard is endomyocardial biopsy, the gold standard investigation for diagnosis of a myocarditis. That you have to remember. So the last question for today we have, it's a young patient who is admitted to the hospital after ingestion of a large number of acetaminophen tablets. So to predict the prognosis using a King's College Hospital criteria in this patient, which of the parameters are not used? It's arterial pH, PT, serum creatinine, or it's a serum bilirubin. So yeah, it's somewhat difficult, I think. But yeah, if you are in a hospital and the patient comes to with the poisoning of acetaminophen tablets, and predict the prognosis using the King's College Hospital criteria in this patient, which of the following parameters are not used? It's arterial pH, PT, prothrombin time, serum creatinine, or it's a serum bilirubin. So yeah, what I think is, So yeah, if you can just tell me the answer here, if you want to answer this. It's a King's College Hospital criteria, that is a prognostic tool for a patient with acute liver failure. So we were thinking of poisoning, but it's a acute liver failure, and basically they have given a criteria for this. But yeah, you have to remember, it's not serum bilirubin. It's a very ironical, but yeah, serum bilirubin is not considered as a parameter for a King's College Hospital criteria, and that too we have arterial pH, PT, and serum creatinine as the criteria for a King's College Hospital criteria for acute liver failure. So yeah, it's liver transplantation is indicated in acetaminophen induced ALF, and if there is a presence of all that given. But yeah, so yeah, it's not bilirubin, it's arterial pH, PT, serum creatinine, and that's all. So yeah, thank you so much for joining for today, and yeah, thank you so much. Take care.